How do I do this? Okay, I think I'm going to mute myself. However, I think I'm going to take uh, the monkey with me uh, to go get my second cup of coffee because I only drank one cup of coffee this morning and I think I'm due for my second one. So give me a moment.
Hey guys, just to let you know that I have a Patreon.
Nice.
If you are interested in supporting me, head on over to patreon.com and subscribe for some exclusive content.
All right, we are live in 5, 4, 3, 2, 1. Actually, we're not even live. The reason. Actually, we're not even live. All right, cool. So kick works. I'm gonna have to copy and paste this. I have no idea why it just kind of decided to the kingdom. Okay. So for some reason, my stream changed immediately on Twitch. Because I was like doing something. Actually, I wanted to start the stream, but then the stream automatically changed to like my TFT stream title. I have no idea why, but anyways, guys, it is another one of these streams. It's a TOTK stream. So let me just see. Okay, good. So we do have game sound, and like I said, it's gonna be another one of those streams where I think I had a study stream last time. It's gonna take a while until the monkey just kind of stabilizes itself, and I think if I'm not mistaken, we do have a good 3 hour stream. This one was a recording that I did for like 3 hours. Um, so we do have that in place. Hopefully, we can get by the whole 3 hours. It's not a lot of stuff that I need to study. It's actually like for an exam that I have uh, tomorrow. And actually, I have not done my second coffee. Give me a second, guys. I'm gonna have to. Crap, how do I do this? How do I do this? Okay, I think I'm gonna mute myself. However, I think I'm gonna take the monkey with me uh, to go get my second cup of coffee because I only drank one cup of coffee this morning and I think I'm due for my second one. So give me a moment. So the monkey still has not stabilized. There's still a delay in this monkey, and I still haven't gotten any comments from either Kick or anything like that. However, the stream I think is going like pretty well. So without further ado, give me a second. Oh my god, that's good coffee. Oh yeah, very good coffee. More like a latte because I like putting milk inside of it. I'm not that much of a coffee drinker or whatever. Okay, so if we go straight into the gist of it, I have a few pathologies that I've learned. As you guys know, the last stream that I did was also a study stream. It was more like an anatomy stream. If I'm not mistaken, I think I streamed it 2 days or a day before. This stream is also a day before the exam. And it's quite different from the other one, which was more anatomy and physiology. This one is more like, okay, here are a few pathologies, here are a few evaluations, and here are a few interventions that you will need to do in order to take care of the following pathologies in each and every patient. So the pathologies that are on the list, including medications, uh, respectively, we have COPD and their exacerbations. We then have neurocognitive disorder, major, mild, and moderate. We then have hypertension. We then have diabetes mellitus. And then finally, we have the last pathology is what a stroke. Anything regarding stroke. Anything regarding stroke. So and including some of the medications. So without further ado, let's start with the first one, acetaminophen. I have a theory. Actually, one of my buddies who was studying nursing with me had a theory that most of the questions regarding medications will not be technical questions regarding. They won't be technical questions regarding uh, like, oh, okay, here is this posology correct? No, this is probably gonna be like, oh yeah, this is where I kind of named my horse Doma. Doma. Ayo Doma. You know Doma? You know Doma? Anyways, so it's not gonna be like technical question like, oh, okay, this is the posology for acetaminophen. No, it's probably gonna be like he has a theory that it's gonna be like, oh, okay, something happening with the onset. There's either something going to be something with the duration of action or something with the peak of action of the medication. So that is why he kind of just started learning just the peak of action, because obviously acetaminophen, the class of it is a non-opioid analgesic slash antipyretic. Um, and obviously the posology is classic for us. We just have a guide of medication. We don't use like a larger one. We just use that nursing guidebook that has the posology between 325 and 650 milligrams every 4 to 6 hours if needed for pain. That is like its usual posology. Maximum for the book, and this is the guidebook. 650 times for, I think it was 3.2 grams per day that you are allowed for a maximum. But most of the books that I've read can go up to 4 grams. It's super weird. And also my military protocols allow me to go up to 4 grams, considering that there's no hepatopathology, right? No underlying cause with the hepatic function. If there is hepatic function abnormality, or if it's a geriatric patient, the book allows you to go up to 2.6 grams per day. And then finally, we have the onset, which is, if I am not mistaken, 30 to 60 minutes, and the peak of action, it is between 2 to 4 hours. I think 1 to 3 hours actually. Whoa, holy shit! I'm just gonna remember 2 hours. Honestly, because they always give you a margin. It is between this and this, and I'm always like in between. I'm never like precisely on the peak. So the peak is 1 to 3 hours. I was right about the onset, 30 to 60 minutes, and I was right about his class. The postology, I did not write it specifically for those reasons that I've had just stated. We then move on to asthma and COPD. And again, it's not like technical questions that I have. It's more like questions regarding. Give me a second. Let me take another sip. Oh my goodness. So fucking good. So fucking good. So, asthma COPD, guys. Um, Again, it's not a technical question like, oh shit, explain me the pathophysiology of COPD. No, it's mostly gonna be like worst case scenario. If I do have to explain a pathophysiology, it's gonna be like um, patient or the family of the patient doesn't understand the underlying pathology. Please explain to them in layman's terms, right? So you got to do a verbatim to those patients. So verbatimly, if we go into it that way, the patient doesn't understand what COPD is. So for the verbatims, there's a few things that you need to do. You gotta acknowledge, first and foremost, the emotion. So I understand, sir, ma'am, or thing, that you're feeling this way. You are feeling anxious. You are feeling stressed out. You are feeling sad. You are not feeling too happy about being diagnosed with COPD. It can cause a lot of anxiety. I'm sure. I'm sure that it is a lot being given, a lot of this information from the doctor. But here's what the general guidelines, what you need to know. So, COPD, and you gotta, and this is where you kind of need to also adapt your language to the understanding of the patient. So, sir, ma'am, or thing, you would need to understand that COPD um, is a disorder that regroups multiple pulmonary. Not the word pulmonary is kind of maybe kind of too rough, but multiple um, disorders of the lungs. So the lungs, which are situated in your chest, um, most commonly, the two main common ones are emphysema, what we call emphysema, which is a degradation, meaning that there is a decrease in. I don't want to say destruction. It kind of sounds too violent. That's why. So okay, let's just say there is a destruction of your lungs, making it that the exchange between oxygen in the air and into your lungs is no good. Okay, so that is one of the most common causes. The other one, the common cause, is chronic bronchitis, meaning that there is constant inflammation, and inflammation is an immune reaction. It is a defensive reaction. It's basically as if it is a constant battlefield in there, right? And when there's a battlefield, it causes a lot of what we call inflammation by your immune system. The immune system being like, think about like the soldiers of your body, right? So these are like the two main ones that occur in COPD. It is a regroupment of diseases. Um, Most commonly cause, and of course there are some factors, sir, ma'am, or thing that cause these. Most commonly ones is smoking, um, and this is where, depending on the case that you get, you could be like, oh, I can see that you've already took the initiative after your diagnosis to stop smoking. So I will have to congratulate you for that. I will congratulate you for that, for stopping smoking and also continuing further in your smoking cessation. It is very important that you continue in order to slow down the progression of the disease. So, encouragement and give hope. I wish you also good luck in your endeavors of smoking cessation and hope that it works. Some of the what is important to know with this disease is that there is possibility, like I said, there is possibility to slow it down. Slowing it down is you've already stopped smoking, which is a good thing. You could also, we highly encourage exercise, movement, mobility on your own time. So it could be as little as being as autonomous as possible in performing your activities of daily life, such as doing your groceries as much as possible, taking walks outside as much as possible, to eventually be able to not feel the underlying effects of the disease. Oh, that's my cat. My cat is probably telling me your verbatims kind of suck. But anyways, moving on. Other things that you can do. It is very important as well to keep taking your medication. Medications that we've seen, and this is not in the verbatim, but medications that we've seen specifically for this. We've seen salbutamol or albuterol, as known in the United States, which is your blue puffer, which is your Ventolin. So that is your rescue inhaler. We don't recommend always taking your rescue inhaler, even though you put yourself in your head that it kind of works, because that is not the medication you take long term to decrease the effects of the disease. What do I mean by that? Your rescue inhaler basically acts fast. It acts at that moment, and it relieves you. Basically, it relieves you for the next 4 to 6 hours, right? With a peak, which the peak is the effects where the medication is at its maximum. It has a peak of like maybe 2 to 4 hours of peak. The onset is probably very fast, 5 to 15 minutes, with a peak. Actually, no, the peak is 1 to 2 hours. So I'm so sorry for that, but 1 to 2 hours with a duration of 4 to 6 hours. Like I said, it is a rescue inhaler. It acts fast, but it doesn't last long. However, your fluticasone, which is your orange inhaler, it's your long-term treatment. What do we mean by long-term treatment? Remember what I said about the inflammation in the lungs, like if it's a battlefield? We kind of give that orange puffer in order to tell those soldiers, hey, stop bombarding the lungs, stop creating a war zone over there. And that is what we do long term. We want to decrease the battlefield that is happening inside of the lungs. So that is why you take your orange puffer. However, most COPD patients do not get an orange puffer prescribed out of the blue like that. You would have needed to have quite a few exacerbations according to the gold criteria. So more than 2 exacerbations, and you need to have had what's it called, a score of greater than 10 in your COPD assessment test, or you would have need to have a score greater than 1 or 2 on the MMRC scale. So the scale, which is the Canadian research measure for dyspnea, which is the MMRC scale. I learned it as the MMRC scale, but I think they want me to write Conseil de recherche canadien. You know, Conseil de recherche canadien, l'échelle de mesure selon le Conseil de recherche canadien. So yeah. So if you don't get prescribed your orange puffer, there is your green puffers. I remember it as green, which is your anticholinergic. So your anticholinergic kind of does the same thing. However, it doesn't act the same way. You were prescribed Seabri, Seabri being one of the medications that we needed to learn for this exam. Seabri is an anticholinergic. It's basically gonna come. It's not going to. It's gonna bronchodilate, but it's gonna act differently. It's basically gonna. Uh, it's going to. I'm trying to like put it in layman's terms. That's why I'm thinking so hard right now. It's going to link itself to the same receptors which tobacco has a high affinity for. So when you smoke, you inhale nicotine. And in your lungs, you have nicotinic receptors, which are sensitive to what we call acetylcholine. And nicotine does the same thing as acetylcholine when it binds, when it has that affinity on those receptors. That is why, in the long run, smoking specifically causes that narrowing of the lungs, of the bronchs inside of your lungs. So the airways get constricted. And here is what this medication comes. So if you've guessed it in the name, anticholinergic, it does not let acetylcholine do its effect. Therefore, if it does not let acetylcholine do its effect, it will bronchodilate. It will bronchodilate. It will ease the narrowing of the airway walls inside of the lungs, and it will permit more airway flow, a more better airway flow. You'll be able to breathe more normally. So Seabri, this one has an onset of 5 minutes, just like salbutamol, very quickly. However, this one will act long term. It will act for the whole day. We don't know what the peak of action is. However, it will last up to 24 hours. This is a medication that you take once a day. It is a small capsule that you insert and you breathe in as hard as possible in order to take all of that little powder. You got to breathe in that whole powder, which is in that little capsule that they give you. So that is all for the medication. Let's see if I was right for that. You guys can rate me out of 10 if you want for the verbatim that I just did. It is quite a long verbatim. How much time did it actually take me to do a verbatim? I think a good 10 minutes. I don't think I'm going to have like 10 minutes to do like those lines, but it is pretty good. It is pretty good though. So salbutamol, I was right. The onset is from 5 to 15 minutes. The peak of action is from 1 hour to an hour and 30 minutes. I'm sorry, not 1 to 2 hours, but an hour and 30 minutes. Glycopyrronium, which is your Seabri, is your anticholinergic. The onset is 5 minutes and the peak is unknown. And I forgot to say, but it comes with anticholinergic effects. However, negligible anticholinergic effects because negligible, I do say negligible anticholinergic effect because it's an inhaled. It is a local medication. It's not a systemic medication. It is very local. It goes inside of the lungs to act inside of those lungs. It will not go into the systemic circulation. However, I think in order for the elimination of the medication, I think at that point there might be something on with that, but we will digress and we will keep going. So as far as COPD goes, and there's also the anticholinergic side effects that I wrote, Alice in Wonderland. We'll get to that. We will get to that. So Chronic bronchitis, we get here progressive and irreversible condition of the lung characterized by chronic obstruction airflow, with many patients having periodic exacerbation, gas trapping, lung hyperinflation, and weight loss. For COPD patients, some evaluations, I always start with fucking intervention, and that pisses me off because I always like to go fast and like to skip to the end. However, it is important to know that some of the evaluations that you can do when you have a COPD patient in front of you, depending on the data that you already have on the paper, I could either do percussion, because in an exacerbation, and especially with somebody that has a barrel chest, so your pink puffers. In Toronto Notes, in one of my textbooks, Toronto Notes says that you want to rule out a pneumothorax, right? When they're having dyspnea. So you want to rule out pneumothorax. So therefore, one of my evaluations that I could do is do a thorax percussion, a percussion on the thorax during my percussion of the thorax in search of I'm not going to say pneumothorax is a diagnosis, but in search of hyperresonance and hypo resonance. So hypo meaning it is matte. It is like a table. It is like completely a table. So that is one of the evaluations that I could do. Another evaluations that I could do for this guy is for COPD patients is I could check for dyspnea according to the Borg scale or le Conseil de Recherche Canadien, which is your MMRC scale. So I could evaluate dyspnea like that, put it out of 4 or out of 10. I could evaluate the pain from the coughing. COPD patients tend to cough in their presentation of the symptoms. They could have a productive, I don't know how to say grasse. Tout grasse et productive, like a thick cough. It's greasy. It's not grease. A heavy cough, like a heavy. You know that it comes from the lungs. I just don't know the word in English for gras. And it's not grease. I know it's not grease. However, so I would like to evaluate if there's any pain with the PQRST. With the OPQRST, I could evaluate if there's any pain regarding the cuff. I could evaluate lung sounds, as simple as lung sounds, bro. Evaluate rhonchi, sibs, crepitus, and the vesicular murmurs upon auscultation. That is an evaluation. I could evaluate the symmetry and thoracic amplitude by allowing the patient to breathe, like taking a deep breath on palpation. And then there's somebody who texted me. Oh, there's a buddy of mine who told me that she found why there is a metallic taste in the mouth for diabetic patients. I'll get to that. I'm just waiting for an answer. So these are a few evaluations that you could do. Some of the interventions that you could do, you could put them in semi-folar, so halfway sitting down to allow for lung expansion. Justification is because it allows for a better movement of the diaphragm and movement of the chest walls. I could do exercises of pursed lips expiration with the patients. That is an intervention that I could do in order to allow for better airflow going out on expiration, to decrease the amount of air trapping. I could do what should I call it? I could do directed cuffing with the patient. That was the word I was looking for. So directed cuffing, meaning that I allow the patient to cuff with me. I make the patient like I force. Oh, oh, damn. Okay, sorry. It's my colleague again. Sorry. Explain the mechanism. Explique le mécanisme. Okay. So where was I? So interventions, yeah, semifolar directed cuff. So we make the patient try to, we stimulate the patient to cuff to clear out as much mucus as possible. We could give him oxygen therapy, in accordance with the prescription, in accordance with the humidified oxygen therapy, or just simply humidified air, medical air, in order to break down and have the mucus be less thick, to have the mucus be more liquidy. So these are a few interventions. And Toronto Note says that here, complications of COPD, chronic hypoxemia, pulmonary hypertension from vasoconstriction, core pulmonale, pneumothorax, and this is where the percussion of the chest wall came in. Emphysemas bolae, depression, bacterial infection. On ABG, retainers have chronically elevated CO2 levels with a normal pH. Maintain O2 sat between 88 and 92 to prevent Haldane effect, worsening VQ mismatch, and decreased respiratory drive. Okay. The first line therapy is smoking cessation. Oh, this is very good. So again, educating the patient. Smoking cessation, educating the patient is an intervention. Patient education is an intervention. Risk factors. Smoking is the number one risk factor. Environmental air pollution. So regarding environmental, let me just take a drink of coffee. Regarding environmental air pollutions is to make sure that the patient has a good and proper hygiene. Good and proper hygiene of like, I don't know, his house, to prevent, like if he has a cat, to just make sure that the hair follicles are not like exponential inside of his house. If there is dust, well, clean your house, bro. If I don't know, make sure to do your respiratory exercises, and also inspirometry. Inspirometry can also help for lung expansion. It could also help prevent alopecia and stuff like that. So this also works as a few interventions. Respiratory infections, depending on the state and the severity of COPD. We could have him vaccinate, yearly vaccinations for pneumococcal, viral infections, stuff like that. There's a few stuff that we can do. Complications, and then there is alpha-1 antitrypsin deficiency. The blue bloater. Okay. So symptoms. So then we go in the pink puffer and the blue bloater. Keep in mind that these symptoms, we've separated these clinical presentations in these categories. However, they could present with one or the other or both of them at the same time. There could be a combination of both. If we begin with the blue bloater, chronic productive cough, purulent sputum, hemoptysis. So another evaluation could be, I will evaluate the consistency of the sputum. I will be looking for hemoptysis, for for like green expectorations, yellow expectorations, stuff like that, that could intervene your evaluation. Cyanosis secondary to hypoxemia and hypercapnia, peripheral edema from reduced ventricular function. My cat actually wants to come on the table. Yo, bro, just come on the table. It is 9:05. Crackles, wheezes, prolonged expiration if obstructive, frequently obese. Emphysema is your pink puffer. He will have symptoms of dyspnea on exertion, minimal cough, tachypnea, and decreased exercise tolerance. He will have signs of pink skin, pursed lips breathing, accessory muscle use, cachectic appearance due to anorexia, and increased work of breathing. So that's also an evaluation here to do. For example, on inspection, I will look for signs of cachexia and accessory muscle use, like intercostal retractions. So like retractions of the intercostals, or like susclavicular, subclavicular retractions. Anyways, stuff like that. Treatment of stable COPD. So now we're going into the interventions. Smoking cessation. So education on smoking cessation. Make a plan. And also just on giving hope to the patient, or giving hope to the family. Oh, and this is another trick. If you're communicating with the family, you make it all about the family and not the patient. And if you're communicating with the patient, you make it up the patient. So it's just like tricks, a few tricks in there, here and there, like that. Annual influenza vaccination, pneumococcal vaccination, and then we obviously have home vaccination. We have gold severity. Remember to step down therapy to lowest dose, which controls symptoms and signs of bronchoconstriction, obviously, depending on the gold. Systemic corticosteroids for obstructive pulmonary disease. Surgical, lung volume reduction surgery, insertion of emphysematous lung with higher, okay, fine. Bronchodilators, short-acting nicotine, okay. Corticosteroids, surgical, and other. Okay, good. Acute exacerbation. Causes. Oh, and for the acute exacerbation. So on presentation, urinary tract infection. It could also, your evaluations could also be, if he has like a Foley, check the urine color, because it could be a urinary tract infection. Or I could have the guy do a quick keto stick, which I remember. Oh damn, okay, she gave me the answer. Give me a second. Oh my god, fuck, she gave me like an inverted image. She gave me like an inverted. Give me, I guess, photo. I guess photos. And I will kind of just see that. Okay. Biguanide. Diminution du production du glucose hépatique. Augmentation de la captation du glucose dans le tissu, surtout dans les tissus musculaires. Diminution de l'absorption. OK. Diarrhée, nausée, goût métallique. Acidose lactique. Le traitement doit être suspendu. Diarrhée, nausée, goût métallique. Le contraste puisse être. OK. Non insuliniques sont des médicaments ainsi que d'autres. Ils peuvent agir sur 4. OK. OK, mais ça dit pas. Ça dit le mode d'action, mais pas le mécanisme spécifique au goût métallique. Like, okay, you know what? I'm just gonna chat GPT it, because basically my colleague asked me the question, why is there diaphoresis? Why is there diaphoresis? And I think it was diaphoresis tremors. No, diaphoresis or weakness or tremors, I'm not sure which, and metallic taste in the mouth. And then she comes up with, well, I said, okay, well, diaphoresis and tremors and weakness are signs of like hypoglycemia. They're signs of like hypoglycemia. But it doesn't explain like the metallic taste. And then she's like, okay, well, it's like side effects of metformin. Okay, makes sense, but why the metallic taste though? And she hasn't found it out. What is the mechanism of why there is a metallic taste in diabetic patients? Because that was the original question. Then she's like, oh, okay, well, it's from metformin. So high blood sugar levels, hyperglycemia, chronic hyperglycemia can lead to neuropathy, including dysfunction of clear nerves involved in. Okay, all right, fine. Medication. Some medication manage diabetes, such as. Okay, all right, good. It is a side effect. All right. Ketosis. In poorly controlled diabetes, ketosis may occur the breakdown of fat for energy. The production of ketone bodies, particularly acetone, can be exhaled or detected in saliva, leading to a metallic or fruity taste. Okay. All right. Oral health issues. Diabetes increases the risk of dry mouth, which can contribute to an unpleasant metallic taste. Okay. Renal dysfunction, kidney disease, and uremia. Accumulation of waste products in the blood can also cause metallic. Okay, I think number 5 is probably like most probable. I think the high blood sugar levels, medication. So let me understand. So what is the mechanism that causes a metallic taste because of metformin? So number 3 is also number 2, which is the metallic taste because of metformin in the mouth is why that is the case. So the metallic taste associated with metformin is thought to arise from several mechanisms. Metformin may directly interact with taste receptors. Okay. Increase lactate production, reduces hepatic glucogenesis. Okay. Gastrointestinal effects. Metformin commonly causes gastrointestinal side effects. Okay. Alteration of zinc metabolism might influence zinc absorption on utilization, since zinc is essential for me. Okay. I think I'll just stay with like buccodental or renal dysfunction. I think I'll just stay with fucking renal dysfunction and waste products in the blood. And the oral health issues. Oh my god, my cat wants me to play with it. He's like fucking making me want to play with it. So back to our COPD patient. Management of ABCs. We said O2 target for 88 to 92. Excellent. Bronchodilators. Teaching the patient how to properly take a bronchodilators is an actual intervention. Okay. Okay, good. Prognosis. I don't need to know about that. ICU admissions. Okay, ventilatory. So everything regarding like escalation of care, like I shown in my RT protocols, I didn't go above and beyond that. We're still on COPD, bro. It's been like 30 minutes. We're like still on COPD. Acute exacerbations, PFTs are not useful. Okay, oxygen, bronchodilators, steroids, antibiotics. Okay, good. Good. Oh, another intervention. You do the Glasgow Coma Scale. You do the Glasgow Coma Scale because if he has COPD and he is at risk of having alteration of gas exchange or hypoxemia, or if he's at risk of going into acidosis, into respiratory acidosis, well, then a Glasgow Coma Scale is a very good evaluation to do for the COPD patient. If he does end up getting hospitalized, a good evaluation is to check the nutrition factor. A lot of COPD patients will not eat properly. They're not going to eat their food in full. Holy shit, it has been an hour of me fucking doing COPD. I am so late. We get into neurocognitive disorders. Neurocognitive disorders that we've learned was some of them was delirium, which is état confusionnel aigu, so acute confusional state. I'm sorry, because yeah, we have to go with like full we have to watch our language. Basically, there's language policing now, because apparently the word delirium is now offensive to a lot of patients, so we don't want to offend the patients, so that's why we are going to change our language. The same thing calling it dementia. We don't call it dementia anymore, no, because it offends a lot of people. No, we want to call it now neurocognitive disorder, because it's kind of like saying the word retarded. You can't say the word retarded anymore because it offends the people who are actually retarded, kind of like me. But me, I don't get offended as easily. But that's just me. I'm just not me. Because it's just me. I'm disgusting. I just quoted Eminem right there. Anyways, in neurocognitive disorder, we learn two pathologies: Alzheimer's disease and delirium. Things to watch for delirium. I have actually. Oh, damn! Thank you, Mosey West. Thank you for joining the stream. So I have an acronym actually to for the risk. Actually, no, not for the risk of the risk of getting delirium. The acronym is Now I'm going to write it in the chat. It starts with I for infection. It starts for W for withdrawal, which includes anything that has to do with alcohol, drugs, and then meds. Drugs are like, I include, when I say drugs and I separate it between like medical drugs and like bad drugs, I'm talking about like drugs. I include crack cocaine. I include cannabis. Actually, cannabis could also be one of them. So I include that. So withdrawal, acute metabolic state. So this includes hypovolemia, electrolyte imbalance. It includes stuff like that. T for trauma. So anything that has to do with like TBI, so traumatic brain injury, or post-op patients are at risk of developing delirium. H for hypoxia. So anything that causes hypoxia. So we've seen it. I have named it in our COPD patient. Anything that alters the gas exchange. Anything that alters pulmonary embolism could be one of them. So stuff like that. So hypoxia. Then we have, I watch D. D is I don't remember what D is. Oh, deficiencies. Deficiencies, which again, we didn't go that far, but Toronto Notes does mention vitamin B12 deficiency as an example. Vitamin B12. E for endocrinopathies. So this one would include diabetes mellitus. A for acute vascular shock. Acute vascular shock. So it could be like an aneurysm. It could be like aneurysms, ischemic embolisms, rupture, like active bleeding, stuff like that. So yeah, basically stuff like that. T for toxins, and this is where we include like hard drugs, like opioids, anesthetics, drugs like hard drugs like cocaine, cannabis, etc. But like not in the so the difference between withdrawals and toxins is like toxins, you are in an overdose state. However, for withdrawals, and it also includes your anticholinergic effects, cholinergic effects, stuff like that. So these ones would include hard side effects, right? Like toxicity because of the drugs. The other one include withdrawal. So, and it's not all medications that end up going into withdrawals, right? You wouldn't have like, I don't know. There's a difference between a benzodiazepine withdrawal and a benzodiazepine toxicity effect, right? Because you took too much benzodiazepine. That's what I'm trying to talk about. And then finally, there is heavy metals. By heavy metals, this includes stuff like arsenic, lead toxicity, and etc. So these are all your common side effects. Well, not side effects, but your risks. These are the lists of developing delirium. I got another image sent to me. I'm just gonna see why. She sent me a reason for the for why there's a metallic taste. And the reason for that is prévenir le patient que la méthamphétamine peut lui donner un goût désagréable ou métallique. Symptômes, OK. Informer le patient qui prend des copies. OK. Yeah, but you don't understand my question, bro. You don't understand.
Je crois que si mettons le genre point, ben ça veut dire que c'est.
She sent me a voice message.
Mais genre s'il y a genre effet indésirable, ça veut dire qu'il est en hypoglycémie, genre dû à la metformine, s'il y a un goût métallique, je pense que c'est ça.
Yeah, no, she's still under the side. Like she sends me stuff. Like, just tell the patient that there's gonna be a metallic taste in his mouth. Tell the patient that it's one of the side effects from metformin. Okay, but why though? Why? And this is where ChatGPT kind of comes in. Effect on test receptors, increased lactate production. Okay, fine. Gastrointestinal effects. Commonly causes gastrointestinal side effects such as nausea, changes in gut microbiome. These effects may lead to altered taste and the perception of a metallic flavor due to changes in the composition of saliva or reflux of stomach contents. It's more like, I would say, composition of saliva makes more sense. Alteration of zinc metabolism makes also sense of why it contributes to that. I don't want to learn on a patient level that it's a side effect, that it's because of this medication and it's perfectly normal. I want to learn on a medical perspective on why the metallic taste of metformin happened. And I think that's what my colleague doesn't understand. Anyways, so neurocognitive disorders, where were we? Oh yeah, I just cited the risk of developing delirium. Clinical feature assessment, common symptoms, difficulty in disorientation, time, place, rarely of person. And some of the evaluations that you can do for a delirium patient is obviously your cognitive assessment method, which is like a little survey that you do in order to see if the patient has delirium. There's a 4AT scale. And there is also the radar, which is exclusive here for Quebec. It is a it's not a direct method of diagnosing delirium. However, it is a more of a scale that lets you predict, is this person within the following days going to develop delirium? So let's say, for example, they get admitted on Monday, you do your radar on Monday, everything looks good. On Tuesday, you kind of just see, okay, well, my radar points kind of increased. Okay, well, I'll probably keep an eye on that. Then on Wednesday, you kind of see, oh shit, okay, it kind of stayed the same. On Thursday, it kind of gets worse, and on Friday, it is worse. So on Friday, that is where you're like, oh shit, okay, he is probably in a state of delirium. I'm gonna do a 4AT, or I'm gonna do a CAM, a cognitive assessment method to see to be able to diagnose delirium. Speaking of which, identify. We kind of just made the iWatch death. If you kind of know, oh shit, I forgot the CNS, central nervous system pathologies or abnormalities. A stroke can cause it because people who have had strokes are at risk of depression, depending on the area that has been affected in their brain. They have like peaks of emotional states. They're very labial states of emotions. So we said infections, withdrawals, acute metabolic disorder, electrolyte imbalance, hepatic or renal failure, trauma, head injury, post-op patients, CNS pathology, stroke, hemorrhage, tumor, seizure disorder, Parkinson's, hypoxia, anything that includes anemia, cardiac failure, pulmonary embolism, Deficiencies, vitamin B12, folic acid, and thiamine deficiencies. Endocrinopathies, thyroid, glucose, parathyroid, and adrenal disorders. Acute vascular shock, vasculitis, hypertensive encephalopathies, toxins, substance use, sedatives, opioids, anesthetic, anticholinergic, anticonvulsives, dopaminergic agents, steroids, insulin, glyburide, antibiotic, especially quinolones, and NSAIDs. So your Advils and stuff like that. Heavy metals, arsenic, lead, and mercury. Okay, good. Identify and manage cause. Evaluations, we said the radar, the CAM, and the 4ATs. Maintain nutrition, hydration, electrolyte balance, monitor vitals are also maintain nutrition, monitor. Well, actually, an intervention is if I write, I will do the surveillance of the vital signs every 15 minutes. That is an intervention because you're doing something, you're surveilling something, but whatever. Oh my god. She's asking me what is the mechanism of action. What does the mechanism of action mean? Si je te dis que le Ventolin, son mécanisme d'action, c'est qu'il se lie au récepteur bêta-2 adrénergique des bronches pour stimuler la production d'AMP cyclique. En retour, a pour effet de faire une bronchodilatation et diminuer l'hypersécrétion. Ça, c'est le mécanisme d'action. So, c'est ce que le médicament fait. Genre pharmacodynamie. I have been your host, AJP, and I will see you folks next time. Thank you very much for watching.
Hey guys, thank you very much for watching the whole content. I hope you enjoyed it. If you want to catch it live, come on twitch.tv/MajinP. That's MAJINNP. I appreciate the support this channel has been getting, which is making it growing bigger and bigger. So please take the time to like, subscribe, and share, and all of that fun stuff. I'm always here trying to get up there, so if you want to support your boy, you know what to do. Thank you very much again for watching, and peace out.